Well, thanks everyone for joining us today. My name is Hugo Carmona. I'm one of the APDs over at the University of Washington. Today we have a great session on bronchoscopy. It's going to be our live virtual boot camp before the in-person boot camp for those who are attending, and some awesome virtual information on bronchoscopy for you all. Before I introduce our two speakers in our session today, just a reminder for those who are attending in person. Check in this year. It's just a little longer with COVID restrictions, making sure that you have vaccine certifications, all of that. So one, look out for the emails from ATS on how to make sure that your vaccinations are proof of vaccination is uploaded. And that Friday morning, the day of day one of the conference of the boot camp for the conference, just make sure you give yourself extra time. The check-in session is in the Moscone North section of the conference center, versus the RBC is going to be in the south, and there's some walking in between those. So just give yourself plenty of extra time Friday morning, or if you're arriving early on Thursday, there's a check-in time from 5 to 7. So regardless, make sure you do the vaccine portion ahead of time and still have to check in day of. So just make sure to give yourself time for that. So with that, I don't want to take any more time away from our virtual boot camp. I'm going to briefly introduce Drs. Van Holden and Darlene Nelson. Both, as you can see, there are program directors in pulmonary critical care medicine, as well as CCIM in pulmonary disease at the University of Maryland and Mayo. We have an awesome session. I'm going to take it away, everyone.
Thank you. Thank you so much for the introduction. Darlene and I are so excited to welcome you all to pulmonary and critical care medicine. We're looking forward to getting to know everyone as future colleagues, and we're excited to share a passion for bronchoscopy with you. So the objectives of our session today are to identify appropriate pre-procedure preparation for bronchoscopy, and this will help to prepare you for the hands-on portion as well. We will describe a procedural approach to airway lesions, which is systematic, and then discuss management of bronchoscopy-related complications. The way that our session is structured today is there will be a 15-minute introduction split between myself and Darlene Nelson. Some of this will include a live demonstration, and then you'll be divided into breakout rooms with a faculty facilitator to work through 2 cases. So when you're doing any type of procedure, it's important to know why you're doing the procedure. And as you'll soon learn in fellowship, there are generally 3 tests that pulmonologists can order: a CAT scan, a pulmonary function test, and then doing a bronchoscopy. So sometimes you'll have a CT scan to review before a bronchoscopy, and one of the indications is if you have an infection, an immunocompromised patient. So you're looking at the CAT scan and seeing where is the area of abnormality, and that's where you're going to target for your sample. Another indication for bronchoscopy is to localize a source of bleeding, identify why there is atelectasis, like here at the right middle lobe. Is there something blocking the airway, or is it mucus plugging? Bronchoscopy is used for lung transplant surveillance to assess for rejection. Patients usually get biopsies about every 3 months during the first year. You can also use a bronchoscopy to look inside the airways to see if there's airway collapse. So you can see the tracheal diameter here is large on inspiration, and then it significantly narrows on expiration. Patients can have lung nodules and masses, especially with the advent of lung cancer screening. We're identifying more and more patients with lung nodules and masses, and those will require diagnostic bronchoscopy for biopsy. And then lastly, mediastinal lymphadenopathy or lymph nodes. So you could be concerned about sarcoidosis or lymphoma. So bronchoscopy is also used to biopsy lymph nodes. Just as it's important to know why you're doing the procedure, it's important to know when you should not do the procedure. And so in terms of contraindications to bronchoscopy, most of them are pretty relative. The ones that would be considered absolute contraindications are patients who are unable to give consent, or they're not cooperative, operator inexperience, and lack of adequate facilities and personnel to care for emergencies. And the relative contraindications include anyone that's had a recent heart attack or unstable angina, decompensated heart failure or arrhythmias, and generally recommend waiting for 6 weeks. And someone who's severely hypoxic or in acute bronchospasm like asthma, you can actually make them worse by doing a bronchoscopy. And someone that has stridor or advanced central airway obstruction, you risk making that worse as well. So you want to evaluate for all of these in your H&P. And in particular, if you see something on bronchoscopy that looks like this is trachostenosis, you may be tempted to push your scope through and think to yourself, oh, my scope fit? Can I just see right past it? Don't do that. So that's another contraindication because you can cause airway edema and then lose the airway that you have, which is already narrow. Other things to consider are risk factors for coagulopathy, depending on the type of procedure you're doing. So think about if they're on Plavix, anticoagulation, are they thrombocytopenic or coagulopathic. Generally, all bronchoscopies could be done on aspirin. And the next step is obtaining informed consent. So as the proceduralist, you want to describe the procedure for your patient and why you're doing it. And typically you start to develop your own narrative. So I would explain to patients I'm doing a bronchoscopy, which is a scope type of procedure. It's a long, thin black rubber scope with a light and camera on the end of it. It's minimally invasive. We would take a look inside the airways and obtain samples. The purpose could be to get samples to look for infection or potentially cancer. The risks of the procedure are generally low, but most commonly you might have a sore throat afterwards, you might cough. The more severe complications can include bleeding, infection, or pneumothorax. All the major risks combined are generally low. And then the patient's responsibility is to express their understanding of the procedure, ask any questions that they may have, and provide informed consent. It's also important that the patients do their pre-procedure checklist, which could include COVID testing and keeping NPO. I mentioned the most common bronchoscopy-related complications, hemoptysis, pneumothorax, and hypoxemia. And in combination, all of this occurs in about 1% of cases. And all of these complications are manageable. During fellowship, you'll do about 100 bronchoscopies. So you will encounter one or all of these scenarios during your fellowship. So how do you manage them? Well, part of it includes being thorough in your pre-procedure assessment. So making sure you do a complete history and physical. Be aware of any concerns or respiratory compromise that may come up. So for patients that have COPD and FEV1 less than 1 liter, you want to be very cautious with sedation. They could become hypercapnic. Patients with asthma, maybe you give them a bronchodilator before the procedure. Assess for any risk factors for bleeding or coagulopathy, and also for any potential difficult airways before the procedure. In terms of lab assessments, you'll do the typical labs like CBC, BMP, EKG. The need for COVID testing is institution dependent, and oftentimes the guidelines can vary depending on the COVID rates in your particular area. You want to review any prior imaging and relevant cardiopulmonary tests that the patient has had. You don't have to have these tests before the procedure, but if they're available, it's important to review them. Provide appropriate NPO instructions. Make sure the patient has a ride home after having sedation or anesthesia. So in terms of doing the actual procedure, this is the typical bronchoscopy team positioning. The patient's in the middle. As the bronchoscopist, you stand behind the patient, so behind the patient's head. Your assistant is next to you, and then you have your nurse and or an anesthesia provider. Sometimes it's another pulmonologist that's providing the sedation. So your assistant could be a nurse or respiratory therapist. They're there to hand you anything you need. So this could include topical lidocaine, doing this saline for your lavage, assisting with insertion and activation of all tools. So your brushes, needles, and forceps. They're in charge of handling the specimen. The other person is your nurse, who administers the medications for conscious sedation and monitors the vital signs, and another provider that directs the medications for the sedation. So you'll notice that if you're standing here, the attending is not in the picture. because your goal by the end of fellowship is to let your attendings sit there and eat their donut and drink coffee. But this is generally the setup for the bronchoscopy procedure. This is a nice overview of the systematic 4-box approach. So you're doing your pre-procedure initial evaluation, check to see if there's any contraindications, obtain informed consent, review the procedure plan with your team, and then make sure you follow the patient results and establish follow-up for the patient. Next, Darlene will be going over additional details of the procedure.
Thanks, Van. I'm just going to bring up my screen here and share it with everyone. So bronchoscopy is by far a hands-on procedure. And so to talk about it virtually is not as satisfying as doing it in person. And so we're excited for everyone who's able to come to the in-person boot camp to be able to put their hands on some scopes. And then for those of you who won't be at the boot camp, when you get to fellowship, you'll get to put your hands on the scopes and actually get to start practicing, which is what makes this such a fun procedure to do. So, but just a little background about what the instrument looks like, so you have an idea. You can see that there's some main parts of the cords or of the bronchoscope. So here's the bronchoscopic camera, which is what is inserted into the patient's mouth or nares, depending on how you're doing the bronchoscopy. This is the working channel port, which is where you would pass any of your instruments to collect samples. Here is your suction port, which is what you would press to get suction. And then here is the control lever. So just to look at that a little bit further, the area of the bronchoscope, this is the tip. And as you can see, there's 2 lights as well as an optic camera, and then what's called a working channel. The working channel is where you both suction through and pass your instruments. So it can be difficult to suction if you have, say, a forceps or a brush or another instrument passed through your bronchoscope. Now, when you pass an instrument through your bronchoscope, it's important to know where it's going to come out on your visualization. So in the standard Olympus bronchoscope, it would come out around 3 o'clock on the clock here. You can see the instrument is coming out at this point on the screen. A thing to note on the disposable bronchoscopes, which are becoming more and more common, such as the Ambu scope, it tends to come out on the opposite direction at about 9 o'clock. So a few more words about the scope, as we talked about with the control lever. When you go ahead and when you push the control lever down with your thumb, it moves the tip of the bronchoscope up. And then when you push the control lever up, it moves it down. So here, we'll play a little video with a demonstration. So you can see he's flexing, or he or she is flexing the thumb up and down, and you can see the change in direction of the tip of the scope. Do that one more time. Okay. So there are some buttons on the scope as well. In the front by the suction port is the picture and freeze button, and this is something that's really easy to accidentally push when you're first learning to do a bronchoscopy. And it's okay if you hit the freeze button or the picture button, just undo the freeze and keep going. Try not to get confused when your picture totally freezes. On the back, there's also a magnify button and a narrowband imaging button, which are used occasionally, but not as common. So here we have a demonstration of one of Van's fellows doing a bronchoscopy, and you can see they're holding the scope in their left hand, which is what's typical. You can do bronchoscopy right-handed, but it was initially designed as a left-handed instrument, and so most people end up holding the scope in their left hand. You typically would advance the tip of the scope with the right hand into the either endotracheal tube or through the nose or the mouth, and then you make motions by twisting your hand back and forth and flexing your thumb up and down. Here again. If you go to the other side, you can see they're twisting their wrist back and forth to look at both sides of the right and left main stem. So whenever, as Van was talking about, when you consider different types of procedures, you're going to consider what type of scope you may need for that procedure. You also want to consider, in order to figure out what type of scope you're going to use, you need to think about the route of entry, whether you're going through the mouth, the nose, the endotracheal tube, through a tracheostomy, and also the purpose of the procedure. What you really need to make sure you understand is how big is your route of entry and how big is your scope, because typically you need about at least 2 millimeters of clearance between the two to be able to ventilate appropriately. You can also collect different types of samples. So as you can see, we have a biopsy needle here, a biopsy brush, as well as forceps, and these can be done to get different types of biopsies, either of masses or nodules. We also will commonly do a bronchoalveolar lavage, and this is in essence trying to collect a sample of the distal alveolus, what the cellular makeup of it is. So if you're looking for infection or trying to figure out different types of interstitial lung disease or eosinophilic pneumonias, and we'll talk about more of this in the cases to come. So tracheobronchial anatomy is also very important and initially can be a stumbling block for a lot of fellows as they're first learning bronchoscopy. And I would encourage you to just spend some time. There are many different apps and atlases and different ways to kind of practice to get to know the nomenclature. Just a few other words about the anatomy. So remember, the trachea has a flexible posterior membrane that moves anteriorly with exhalation. The distal margin of the trachea is indicated by the carina, and in adults, it's about 9 to 15 centimeters in length and 7 to 10 in children. And here is just a picture of the trachea in cross section. And so this is a very common view you're going to get familiar with, and it's important to understand what's behind your view. So just a few more words about bronchial anatomy. So on the right side, as you know, we have 3 lobes with 10 bronchopulmonary segments, and on the left side, we have 2 lobes with also 10 bronchopulmonary segments. And I didn't want to spend too much time bogging you down with anatomy because really it just takes some time practicing. And if you have a simulator at your institution, that can be a really wonderful way to also practice anatomy and get familiar with it. But just as Van had mentioned earlier, it's important to have a kind of a systematic approach anytime you approach a bronchoscopy to make sure that you limit your complications and make sure that it is a safe procedure for the patient. So with that, I want to get us off to our cases so we have plenty of time, and thank you all for joining us again today. I'm going to stop sharing.